We'll make a start. Hello, everyone. Welcome to the next COVIDsurg webinar. Today, we're going to be looking at the first data released from the COVIDsurg cancer study. So whilst COVIDsurg was taking place and the data we released, we were also asking you to collect patient-level data on those undergoing elective cancer surgery during the pandemic. Now, there have been lots of models around cancer surgery and COVID, but this is the first international multi-center patient data set that is going to give you patient-level data. That means it's real data, it's hard data. And I think what we need to do is take this data and discuss how we're going to use it to speed up and improve practice for our patients around the world. It's a pleasure to introduce a global panel today. So Malin Sund is an endocrine and oncology surgeon from Sweden. Hello, Malin. Thanks for joining us.
Hi.
Neil Smart is a colorectal surgeon from the UK and is editor-in-chief of Colorectal Disease. Hello, Neil.
Thank you for having me.
I'd like to say good afternoon, but from all the countries dialing in some places it's good morning, some places it's good afternoon, some places it's good night. Dhruv Ghosh is a pediatric surgeon and he's the director of the global surgery unit at CMC Ludhiana in India. Hello, Dhruv, thanks for joining us.
Hi, Anil. Thank you for having me.
James Glasby is a PhD fellow and mid-career surgical trainee in Birmingham in the United Kingdom. And he is the principal investigator of the COVIDsurg cancer platform. Hello, James.
Hi, Neil. Lovely to be here with everyone.
And my name's Anil Bangu. I'm a colorectal surgeon at the Global Surgery Unit in Birmingham in the UK. And I'm the overall chief investigator of the COVIDsurg platform. So to start with, what we're going to do, we've got two presentations and then we've got some discussion. Please type away with questions and we'll be answering them during and even after the presentation has concluded. The first presentation is going to be from James Glasby. So James, if you get your slides up, and this is going to be the first look at the methodology and the early results from the COVIDsurg cancer study. So James, I'm going to pass over to you, please.
Thanks very much, Anil. I'm really honoured to be here with you all today. Today we're going to look at the first look at the data from the fully locked COVIDsurg cancer cohort. And we're going to specifically be looking at this issue of resilience of elective cancer surgery. So were centres able to maintain capacity for safe elective surgery during COVID-19 lockdowns? And of course, most importantly, this would not have been possible without our collaborators and leaders all around the world. So huge thank you to everyone that participated in this study and congratulations on all your hard work to date. It's been a pleasure working together. A big thanks also to our sponsors and charity partners without whom this would not be possible and funded us at a time which was very hard for charities all around the world. So first of all, this is proper breaking news. We often publish these webinars after the data has been released and use them as a vehicle of sharing the data. But this data is actually under consideration with a journal at the moment. So please do not tweet and share these things at the moment because it could get me into trouble. And I'll pass that trouble on to Anil very graciously. So please, we're delighted to share this with you today, but please keep it under wraps for now. So why is delays and cancellation of surgery important? Well, when people are diagnosed with cancer, as we know, they undergo they have some symptoms, maybe undergo a diagnostic test, discuss in a multidisciplinary team meeting, or have a discussion between surgeons, depending on where you are in the world. And then there may be a decision where they go straight to surgery or perhaps have some kind of neoadjuvant therapy. And there can be delays introduced at parts of this pathway. And specifically in this study, we looked at people with a diagnosis of cancer and delays from their diagnosis date to when they were discussed in an MDT meeting or had a decision about surgery or other therapy. and then from that decision to their operation itself. So we can't comment on delays in the diagnostic phase, so pre-people's getting a diagnosis of cancer, which is an important thing as well. And sadly, during the pandemic, we saw a huge growth in these delays and even cancellation of surgery, where people may never get the operations, the cancer operations that they require. So this is the importance of having a resilient surgical system to reduce these delays and prevent people from having not receiving the surgery that they need. And why is this important? Well, there's an excellent review I'd point you towards in the BMJ, which showed that for every 4-week increment in delay from diagnosis and patients not receiving the adjuvant therapy, you have an increase in long-term mortality, reduction in survival. So even small delays and the eventual kind of outcome of actually not having an operation could have really significant consequences for our patients. So what do we seek to address with this analysis? Well, we wanted to know, were elective surgical systems around the world resilient during COVID-19 lockdowns? So kind of government level restrictions to movement and travel and different parts of health policy. This concept of resilience isn't new, but it's quite new in the field of surgery and elective surgery. And actually, COVID-19 is not the only example of an external shock which can affect hospitals. And in the UK every year, we see cancellations of large volumes of elective surgery due to flu pandemics and other winter pressures, such as lots of elderly people falling over and having hip fractures and things like that. So what we've defined resilience as here is a hospital's capacity to maintain volume for a safe elective surgery during periods of higher pressure. And this is how we sought to address it. So uniquely in this data set, and I think this is where we've got a difference to other data that's been published, we were able to track patients forwards from their decision for curative cancer surgery, and then look at their pathway and see where they ended up, and whether they had their operation, when there was any delays, what sort of therapies they may have received, and whether that was a normal thing or something which was COVID specific. And we work with some amazing partners from all around the world across 10 different surgical oncology disciplines to make sure that the case report forms and the protocol were really targeted to different cancer types. So huge thanks to our collaborating lead investigators across the cancer types. So we worked with centres from when there was the local emergence of COVID-19 up to the end of August. And for those that were involved in the study, this is effectively group 1 patients, where all of those patients were identified from the MDT. And it was across all 16 most common operated tumour types. Now, the next question was, how do we define COVID-19 lockdowns? And you might think if you're out on the street and there's a lockdown, it's pretty obvious. This was central London in the midway through the lockdown. And I can tell you, usually there'd be sort of several million people in this circle and it'd barely be able to move. And during lockdowns, we saw this huge reduction in travel and mobility. Fortunately, someone did the hard work for us, and there was an Oxford COVID-19 Government Response Index, which was published in Nature, which effectively looked at the stringency of measures to affect things at a population level and quantified it in a way that we could use it for analysis. So this was well validated for policy measures, but we think we're probably the first people that have used it in an academic paper, so a novel application perhaps. What we did is we took every patient while they were waiting for surgery, so from their date of diagnosis or the start of the pandemic up to the date where they had their operation or they finished follow-up, and we calculated a median over that time. So we had some idea of what they were exposed to during that time period. So maybe they had a wait for 2 weeks in a period of light restrictions, and then a more prolonged period in full lockdown, and we were able to account for some of that variability. And this is how we defined our COVID-19 lockdowns at patient level. So for patients with a score less than 20 on this measure, we called that kind of light restrictions. And we think that's effectively as best as we can get to business as normal. So we can make an internal comparison within the data set. And then for some patients where there were very stringent measures, then they were under kind of full lockdown restrictions. And then for some patients where there were perhaps regional lockdowns or there was a little bit of limitation, they were defined as being in a moderate lockdown setting, and happy to discuss that further. Our primary outcome measure for this analysis was non-operation, so patients not undergoing the cancer surgery that they were planned to have. Every patient had a minimum of 3 follow-ups, but for some patients that was as long as 6 months. And we classified an event if it was an elective or emergency surgery, because certainly in our hospital, some elective operations became emergency operations if we were trying to kind of get people in on the list that we couldn't do electively. And there were also kind of change in operation intention or urgency of surgery. They were also included as an event. But if patients died or got unresectable disease, sadly, they were classified as still being non-operated up to the end of the follow-up period. So of course, we've got time to event data. So we used Cox proportional hazard regressive model, which allowed us to adjust for patient, disease, and operation level factors in working out whether there was an association between the lockdowns at country level and the risk of non-operation for patients. We also looked at the number of weeks that people waited in full lockdown and to see if there was an association there between that and the risk of non-operation. And we asked, is this all just about SARS-CoV-2 rates? And in the UK, and I'd love to hear the comments from the international panel, there would be waves of high SARS-CoV-2 rates, and then the rates would drop, but the lockdown measures would continue as the hospitalizations were still high and we were unsure about the next kind of waves and things. So we looked to see whether that was just describing all the variability in non-operation that we saw. So first look at the results from me, and then we'll go to some discussion and questions, and then Drew's going to give us a deeper look into the results. So in this analysis, we included 20,000 patients from 61 countries, so a really big generalizable sample. And this was across high, upper middle, and low middle income countries, with about 80% being from high income countries. Included a wide range of cancer types. The biggest contributors were colorectal, gynae, and breast, as you might expect just by cancer volume. And this is the first important headline that we'd like to show to you today. So in periods of light restriction, which we think are sort of normal circumstances, 0.5%, so 1 in 200 patients didn't go on to have the surgery that they were planned to have. However, in full lockdowns, 1 in 7 patients, so 15% of people, didn't go on to have the operation that they were planned to have during full lockdowns. And moderate lockdown, we saw something in the middle. So we saw a large effect here, and I'd love to discuss further whether we think that this was robust to other variables that could explain this difference. So that's it from me, and I'd love to take any questions.
Well done, and thank you very much, James. Before questions, and just before we move on to the next speaker, who's Drew, 2 things. Firstly, could we launch the first poll, please? So we've only got 2 short polls. We just want to see how this data fits with you and your capacity. Second, I've got a question first for Marlon and Neil. So Marlon is an editor for the British Journal, BJS, British Journal of Surgery, and Neil, editor-in-chief of Colorectal Disease. So you guys have both seen a lot of data and papers passing your way over the years. We'll start with Marlon. Just for context of everyone, do you think that this type of, I don't want to lead you, this type of patient level data is valuable in context of the models? Do you think it's worth going out and getting this sort of data? And from your point of view, how does this patient level data affect reliability when you're looking at a manuscript?
No, I absolutely think that is very valuable, because modeling is still just modeling, and even if it's good, it's not evidence as such. So, and to have this real world evidence that we have here from several different scenarios, I think it's extremely valuable. Absolutely.
Thank you. So Neil, I'm not saying that models are useless, but you know, this was a major effort, and you know, credit to James for helping direct everyone through it, and to our many collaborators and supporters. I'm trying to check for the next half of the presentation. Does this fill you with confidence about reliability, or do you think this type of data becomes less reliable than the models? What's your experience been?
No, I echo what Marlon has said. I think it's incredibly important to have real world data like this. And I think the great thing about it is the breadth of hospitals that have taken place, all different types, and the different types of countries. And I know there's a preponderance of high income countries, but we've got upper middle, low income countries too. So we've got great external validity here. So the global applicability is really there, and that's the great strength. And the models can't compete with that. And I think that's its great advantage.
Thank you. So Dhruv, I'm going to come on to you next and ask you to load up your slides for the second presentation, please. And while, there we go. Are you ready, Dhruv? I'm going to pass over to you now.
Thanks, Anil. Can you see my slides, I guess?
That looks good. You ready to go?
All right. Thank you, Anil, and thank you, James. I'll just talk about a bit from our study about the resilience of elective cancer surgery systems during the COVID-19 lockdowns, and this is from the beginning of most lockdowns across the world till August, as James has already told us. The question that came to our mind when we were starting the study or prior to this was the findings that could come out of the study, and later as well was the finding related to a case mix alone. And we found that the fragility of elective cancer surgery systems to various lockdowns across the world was independent of the local COVID-19 community infection rates, as well as the case mix that was presented by James earlier. We adjusted the model, as James alluded earlier, and we adjusted for patients, disease, operation, health system level factors. In a consistency reduced hazard ratio was observed during the study. This sort of means that after adjustment for several confounding factors, we found that patients waiting for surgery during full and moderate lockdowns were less likely to have the planned or needed surgery for cancer that was planned earlier. We found in our sensitivity analysis that after adjustment for everything, that this was independent of the community COVID-19 rates. As well, we looked at elective surgery as the only event. That means patients that underwent emergency surgeries were coded as non-operative. We also looked at hazard ratios in our patients, and looked at the number of weeks in full lockdown, and we found that patients with more than 6 weeks in full lockdown were associated with non-operation. That means patients who had been in lockdown for more than 6 weeks had a higher chance of not having their required surgery or their needed surgery in the study. The next question that we sort of looked at were which patients and countries were particularly vulnerable to lockdown effects. Now, the study was conducted across high-income countries, high middle-income countries, as well as low-income countries. And our study sort of showed that frail patients who had ECOG score of more than 0 or a cardiac index of more than 2 had a higher chance of not having surgery. And we think that it's probably related to the fact that these patients would have required post-operative intensive care. We also found that patients with locally advanced nodal cancer were more likely to remain non-operated. Then there were some specific specialties like esophageal cancer, gastric cancer, and pancreatic cancer, surgeries which probably require intensive care after the surgery. And these were cases which had a higher chance of not being operated. So they were a vulnerable population. Similarly, where there were other treatment modalities present, for example, prostatic cancer or receptor-positive breast cancer, we found that the chances of them going on to other modalities of treatment was higher, and the chances of being operated was less. Amongst the countries, during light restrictions, we saw that the non-operative rates were pretty similar across various income countries. But in moderate and full lockdowns, patients had a higher chance of not being operated. And this was particularly observed in low middle income countries. When you look at the numbers there, full lockdown, high income countries had a 13.7% chance of not being operated, which increased to 24.2% in low middle income countries. So in effect, what happened was that the chances of a patient not having a surgery in low middle income countries was 1 in 4, while in the entire cohort, the chances of them not getting surgery was 1 in 7. So this effect was exacerbated in low middle income countries and even in some cases in upper middle income countries during full lockdowns. So it sort of reveals to us a fragility of an already under-resourced health system, and more importantly, an under-resourced surgical health system. The fragility was already probably present, but the COVID pandemic seems to have sort of exposed it to all of us, unfortunately. What happened to the patients that did not get operated? We had about 2,003 non-operative patients. And in the data that we collected from our clinicians across the world, we found that almost all of them had at least one COVID reason for non-operation. 4% of these patients, unfortunately, developed new metastatic disease. 8.9% progressed on to unresectable disease, and about 2.4% died before they could get a surgery. Amongst this 2.4% who died before getting surgery, almost half had a COVID reason or a COVID-related reason for their mortalities. Now, this is a very small group in the context of the entire cohort. However, it speaks to a potential harm suffered by patients because of a non-operation. We also have to realize that the study has a short-term follow-up rather than a long-term follow-up. And in the short-term follow-up, we are already showing harm. So the question begs to be asked is whether in the long-term follow-up, this harm is going to be multiplied. Long-term follow-up was not available with us, but we feel strongly that long-term follow-up probably needs to be done. And once that happens, we may see an increase in global cancer mortality as a result of the cancellations that have happened in the last 2 years due to delays or due to COVID-19 directly. What does this mean for global surgery? And there's sort of a take-home message that we have. Elective surgery systems were fragile in lockdowns. We've seen the health system across the world were fragile to various lockdowns. But the systems for elective surgery, and still happening with various waves of the pandemic coming, the lockdowns have exposed a huge fragility in our surgical systems. We've seen that there is primary evidence of collateral impact, or want to put it as collateral damage of the pandemic to surgical systems, especially surgical systems related to cancer surgery. COVID-19 has uncovered an existing fragility of various systems, especially in low and middle income countries. And this fragility, we would say, is not just before COVID-19, it's probably related to all kinds of system shocks, which might be happening or will happen in the future. It's just that we've not paid attention to those shocks and to the fragility of our systems. Surgery underpins the care for many non-communicable diseases, and not just cancer, and is the primary method of disease control in a majority of solid cancers. And here we're just looking at adult cancers. I'm sure it's the same for pediatric cancers as well. Like I've said, there are other system shocks that also exist, which will affect the capacity to do safe surgery. So it begs the question whether health system and hospitals must provide long-term investment in protective pathways for elective surgery. And probably this research and this data points towards that protective pathway for elective surgery and an investment in surge capacity for acute care, along with other public health emergencies. So in effect, what we are saying is that elective surgery cancer especially, should be treated with the same respect and the same urgency as a public health emergency. Thank you.
Very clear and well done, Drew. Thank you very much. I will come to you with a question in a moment. We've got a few questions in from outside, but two things first. From the poll we sent out, only 10% of people maintained normal capacity for cancer surgery. And actually 84% of people stopped some or all elective surgery. So that from our viewers, that cross-checks with what we've presented. Now, there's one, I want to go to James. I'm going to ask you a technical question. I'm going to give one view of that, and I'm going to ask you just to give another view. My view is that the lockdowns impacted on elective cancer surgery independently of COVID rates. That means it wasn't just a function of the community COVID rates. It wasn't just high COVID rates. I could be under a hard lockdown with low COVID rates. I could be a hard lockdown with high COVID rates. But there's something else about the processes and nature of the lockdown that led to these scenarios. Is that a fair comment?
Thanks, Anil. I think it's really important to say that, first and foremost, lockdowns are an essential public health measure to reduce infections in the community. And this data is absolutely not anti-lockdown. So hopefully I won't see my name in the Daily Mail in the UK tomorrow. But certainly when governments are making decisions about whether to extend lockdowns, then there does need to be primary data available about some of the collateral impacts. And in our data set, it looked like regardless of the SARS-CoV-2 rates, so when that variability was removed, there was still this kind of independent effect of lockdowns. And I actually saw that borne out in our clinical practice, where there was these stringent government measures in place. And the hospitals as well had to kind of reflect that. You couldn't have a business as normal hospital, perhaps, whilst there was very stringent measures in place. So I do think there is some kind of independent association between population level measures and what happened at a hospital level, which is important to consider.
Thank you. Dhruv, over to you. So what you've suggested is that no one was immune from the impacts of lockdown on their cancer surgery, but probably things were tougher in, let's say, middle income countries where there is a huge volume of surgery. Does that reflect what happened in India? And are you seeing that as wave after wave comes?
Yeah, I think speaking for where I come from, and I think a lot of my colleagues here, if they understand the numbers, especially in India and many low and middle income countries, would be very high for COVID. And similarly, the numbers for patients with different types of cancers would be also very high. We've captured, I think in India, we've captured data from about 15 hospitals, and I'm sure there are a lot more hospitals where we've not captured that data from. Now, as James says, lockdowns are necessary to control the pandemic, and this paper is not talking about stopping lockdowns, but the effect of cancer surgery for many of our patients in many of the lower middle income countries is the fact that it will affect not just the fact that the patient is not getting cancer surgery or is suffering from cancer, or his cancer gets upstaged or becomes unresectable, has metastasis. There are long-term effects, but also there are economic effects associated with that in terms of families. The breadwinner is the person suffering from cancer. They are very far away. They are not able to access, and it's not because the hospitals are not able to do that. It's just that they're not able to access the hospitals because they can't travel. A lot of things that would probably go into that, and the effects will be multiplied in systems where the healthcare is not so robust and not so easily accessible, especially in big, large, diverse countries. Yeah.
Okay, thank you. Neil, one of the things I took from the data is that during the sort of either no lockdown or very light lockdown, only about 0.5% of patients did not undergo surgery, whereas during a hard lockdown, that number accelerates to 1 in 6, 1 in 7. What would you say? Do you think that not performing elective cancer surgery is business as usual? Does this just happen anyway? Or are we in a period of time where we're going to have to do things differently to provide, I'm going to be contentious, an operation we promise?
I think there's some challenges, aren't there? And I think different healthcare systems will have different problems that are unique to them. Certainly within the UK NHS, one of the issues we saw was that during the surges and the lockdowns, we saw people redeployed away from surgery. And so even though the patients were there, they were fit, and perhaps some of the surgeons were there and available to do the work, we couldn't actually get access to theatres, they couldn't staff the theatres may have been converted to intensive care rooms, again, for ventilation. We're really struggling, there isn't that resilience in the system. And I think many places have described similar things. I know in other countries in the world, even the surgeons have been utilised as teams in intensive care units for turning patients over, even doing intubations. We're going to have to get better, I think, because this is only the first time this has happened, and we're going to see subsequent waves. We've got Delta going on at the moment around the United Kingdom and around the world, about how we say you can't just rob Peter to pay Paul, taking away the surgeons from their core activity to go and do something else comes with significant harm. And we now see that from this data. We've seen the rates of people developing new metastases, unresectable disease, dying while they're waiting, levels which are really quite unacceptable and perhaps more harm than there was actually anticipated. So we're going to have to get better. We need to figure out how to do business as usual all the time and maintaining that.
Thank you. Marlon and I were speaking beforehand, so Marlon, over to you, about what I would consider to be the big question. Are we ready for next time? So could we launch the second poll, please? We're going to ask our attendees, how prepared are you? How prepared are your elective cancer services for another COVID-19 wave? Marlon, I'll ask you that question. And are you worried about COVID-19, or are you worried about other pandemics, and are you ready?
Well, I think that this pandemic really exposed how vulnerable our system in Sweden, at least, was. We knew this from before. We have had a lack of hospital beds, of ICU beds, for a long time. But now this pandemic puts such a strain on it that it really was clear that we have to do something. And I don't think it's related only to the pandemic. I think this is something wrong with the system itself, at least in my setting, where we cannot work as effectively as we should in elective cancer surgery. And there will be more pandemics, there will be more strains. And so really now we know what to do. We just have to see that it gets done now. The changes.
So around where I am, it's our emergency departments are very busy, but it's mostly non-COVID related stuff. And so it's absolutely straining our already strained system, which is making planning surgery really difficult, because there's, the phrase we use is there's not the headspace. We're just fighting what is coming through the front door. And Dhruv, you're in, I know you're just visiting Oman at the moment. So you're physically just at the moment in a slightly higher resource setting. I'd just be interested to pick your brains and find out, how is Oman? Are you getting surgery done there? Do you feel prepared for the future?
No, I agree with what Marlon is saying, because it doesn't seem to be a problem that is just isolated to low and middle income countries with poor resources. I think high income countries are as, if not more, unprepared to do this than low and middle income countries. You have to realize that the population in middle income and low income countries is much higher than most high income countries. And so you would expect that the systems will be able to absorb shocks in a high-income country, but that's not the case. And we've not been able to do elective surgery regularly for some time now. And I'm sure a lot of the cancer patients are suffering or looking for other avenues for treatment, etc. Even in high-income countries, even in countries which are supposed to have resilient systems. So agree to what Marlon is saying completely, that this pandemic has exposed the fact that our systems are not resilient. It has also exposed the fact that we across the world have not invested in surgical care, and especially surgical care for cancer. We've sort of looked at other modalities. There has been, I personally feel, a lot of investment in other modalities, and it's about time that policymakers in hospitals and in the healthcare system decided and thought about investing more in resilient surgical cancer care systems rather rather than other modalities.
Thank you. We've had a couple of questions come in. So how do the panel think we can improve the resilience of our hospitals to be better equipped for the future? So I'll ask that to everyone. We'll start with James. James, a question. Do you think people can use this data and use it locally? And if you could give people one message that you've seen in the data for change, what would that be?
Thanks, Anil. Yeah, I think COVIDsurg has really highlighted kind of the surgeon as the change maker. And we've seen lots of feedback from collaborators all around the world about how they've taken data to their local management meetings and try to implement change. And I think this is a really good example of where data can influence local, national, international policy. I think as a first example, our previous analysis from the COVIDsurg cancer early data set around COVID-free pathways and these protective elective surgical pathways. So, a separate admissions area, separate ITU beds, protected theatres and protected wards, having that provision of a pathway where patients can flow through the hospital, and it's always dedicated to some extent to elective surgery. I think it is one really important takeaway which we can take from this.
Thank you. I'm going to pass that same question around, but I am going to caveat it that we know that this is a challenging area, and I don't think any of us are suggesting that anyone watching or anyone watching in the future can do one simple thing to change huge systems. But I like your phrase that as the patient advocate, as the change maker, we can equip you with the data to sort of take away and at least look at your local systems. So Marlon, can I go to you? What do you see as changeable in your systems and around you?
Well, I think we need to be very honest about, so the number of cancer cases doesn't change. It's pretty constant over time, and we know what's needed in order to do this at a good speed. So it's very surprising to me that we cannot manage to really, you don't have to be a math wizard to calculate how many beds you need and how many theaters you need to manage this. But somehow, I guess it's a money issue at the end of the day. But I think we need to show this data to our policymakers to really, give them the power to implement change that is needed.
So maybe we can think about doing even more with this data and creating downloadable presentations, allowing people to take it to their national societies and say, during periods of social pressure, and I'm going to go out on a limb and say this extends to winter as well, our patients are likely to suffer unless systems are in place. Neil, do you think, does that resonate with you? Are you worried about another wave of COVID and winter? Can you see any change around you that would be feasible?
Yeah, I think I'm worried about further waves. I don't think we're out of the woods yet, certainly not internationally. And we hear about new variants of concern almost on a weekly basis, and whether one of those will be not susceptible to the benefits of vaccines that we've got, who knows? Only time will tell. So yes, that worries me. James has spoken very eloquently about the physical concepts behind ensuring resilience of cancer care, and the whole concept about having either dedicated pathways within a hospital or even dedicated hospitals which are ring-fenced. And that's great, but I think what's perhaps more important is actually the human elements of that, and about who staffs it and how we prioritize that staffing and who does what within it. And I think particularly in some healthcare systems where there's been an insistence on equal shares, or if you've got, say, 10 surgeons who all do colorectal cancer, for example, do all 10 of them still have to do cancer during our surgeries at times of complete stress, when we're facing pandemics and we've got high community rates and there's other pressures on the hospital? Or do you ring fence things down and redeploy a subset, but maintain a subset who are doing the cancer work? And again, for our nursing staff, we have to look at that really carefully, because how we staff our operating theatres, who's going to staff the recovery room areas. We need to get that sorted and saying to these people, we're going to have to make sure that you're not the ones who are taken away, because it's really easy to come along and go, we've got this pressure and you're going to have to come here to sort out this number of COVID patients. But then if you're not careful, that entire house of cards that cancer care is built on will go. We have to look after the people who are within the system to make sure it keeps working. And I don't think we did that during the first waves, certainly not in the United Kingdom, possibly in many other healthcare systems in the world too, from what I heard.
And speaking of which, Dhruv, in India, we saw the sort of severity of the last wave. I guess as new waves are coming and going, are you testing in elective surgery? Have you got COVID-free hospitals and pathways?
Well, not across the country. I'm sure there are some hospitals which have developed on their own COVID-free pathways and for surgical care. It's very frustrating for surgeons, and I'm sure that resonates across the world when you are just sitting and twiddling thumbs and not able to do things, and you're seeing disease progressing. For some, I feel that policymakers have to realize that while the pandemic is a serious affair, there are other diseases which will cause as much grief to families and mortality and morbidity. And something needs to be done. We are not at the beginning of the pandemic anymore. We are way down the pandemic. So surgical systems have to be developed everywhere. And I think the message that probably should go out of this data set and the paper that comes out of it is that it is imperative that for many non-communicable diseases, and especially for cancer, surgical systems have to be robust and have to be free of any kind of pressure from the pandemic, the present one, and like Malin said, the ones that will come in the future. It has to be done, otherwise there will be huge implications, and not just health implications, there will be economic implications to that as well.
Well, the results of the next poll have just popped up. So how prepared are your elective cancer services for another wave? So 51% say either not very well prepared or unprepared. And I think that sort of reflects what we've said. 14% are well prepared. And I think it's worth talking about that 14%. Some places are well equipped with standalone centres and different systems and different processes. I know some part of Western Europe got back to business pretty quickly. And I think, that's really impressive. But not everyone is prepared, I guess, is the message from that poll, which is very interesting. We've just had another couple of questions come in about prioritization. So this is going to be a hard question. I'm gonna ask you all. Do we need to change the way we prioritize patients when we are under severe limitations? And I'll try not to get too specific, but there are arguments about different types of surgery. There are arguments about the effects of delays on different types of cancers, early stage versus late stage. And I think as James and the team continue to analyze the data, we will be able to feed data to inform these decisions over the next 12 months. It's the world's, and I mean this legitimately, it's the world's richest cancer data set now. If we just step away from that, let me change my question. Do you foresee the need to change the way we are prioritizing elective surgery? Malin, to you first.
I think this is a very central and important issue, and it's something that we have been struggling with in Sweden for years, about how to do this horizontal prioritization, both between specialties, but also within disease groups. And I think now that we have this data set, we really should look into it. And I also wanted to just add something about how we could use this data. Really, in cancer treatment, surgery is the cheap part. It's much cheaper than a lot of the other treatments that come along. And I think we need to really make our policymakers understand that if you just keep the surgery rolling, then we are putting people in a better place than if we do not. So these are important issues. And the prioritization is a part of that.
Neil, same to you. As things roll on over the next 12 months, do you foresee tough decisions on priorities?
Yes, lots. We've had those discussions locally here. There's been difficulties where specialties have come into conflict about perceived prioritisation. There's been challenges as well for hospitals where some specialties which are predominantly elective haven't been able to do their cases, particularly because they are more quality of life orientated. Our orthopaedic colleagues have found that very challenging. But there have been some unintended knock-ons, and certainly we've noticed, and I'm sure data will come out in due course of other places in other countries too, that there are some benign conditions that don't get operated on because of the pandemic, but which have the tendency to cause significant morbidity and mortality and can use up significant resources. Yeah, initially, but then of course they're now causing all their problems, like you highlighted before. You know, we see ITU capacity is reduced because of it. So, yeah, ongoing knock-on effects, difficult, really hard.
Thanks, Neil. I lost you in the middle there, but you're back now. So, Dhruv, let me just pass over from what Neil was saying about, do you see this, have you seen problems in non-cancer ped surgery?
Yes, I think we've seen huge problems in non-cancer ped surgery. And while we would think that this is non-cancer and non-emergent, but we have to realize, especially in congenital surgery, the effects of not doing the surgery at the right time has long-term problems in the outcomes. And so this is a huge problem. Prioritization will be very, it's a tough question. It will be difficult to answer, especially in resource-constrained settings. There will be cruel decisions that will need to be taken, and it will have to be done. But again, policymakers have to realize that surgery is important and surgery is curative, both for cancer as well as for non-cancer conditions. So there has to be more effort and more investment in surgical care across the world now.
I'm going to hand over to James in a minute. So before we talk about the next project, I'm just going to talk about a really early thing we're planning, and it's an open call for collaboration. As I've read around, and if any of the panel correct me, that would be great. I've seen a lot of work on pandemic recovery and planning for next pandemics. I can see no inclusion of surgery in those major global plans. I know there is a Lancet commission on pandemic recovery, and there is no surgical representation in that group, and surgery is not being discussed. And I think we've reached a stage where there are existing problems, there's current pandemic and there's future, and we're trapped in the middle. And Dhruv has commented on some of that, as we've seen the problems in middle and lower income countries. So what I'm proposing is that we bring together our stakeholders, our national associations, our global associations, and we create a series of 3 position statements, 3 articles, which will look at a global surgical recovery series. And we start to map out what we need for the future and what we see as realistic. Why does surgery matter? Why do we need to be prepared now for what's coming next? But also, what is the role of innovation? I don't think any of us just want to provide the minimum surgery. We want to be providing the best surgery. So how within a scope of recovery can we still innovate digitally, technologically, and through research? So I would like to just place that as an open call for collaboration and ask you, if you have links into national associations, can we come together at the start and start planning out what will be the world's leading piece on recovery of surgical services? But look, I'm gonna draw it to a close there. I think these are difficult issues, but we're trying to tackle them head on. So Marlon, thank you very much. Neil, Dhruv, thank you very much for your time and for joining us. James, well done for putting up with me. I know this throughout what has been one of the world's most challenging surgical studies. But one thing I'll leave everyone with is this data is valuable because it is prospective and it's patient level. No other study in the world's ever captured decision making around these issues. They've all been retrospective models. So well done, James. Good afternoon, good night, and good morning to everyone. Thank you for joining us.